Michael, the floor is yours.
Thank you, Ahmad. Thank you, the chair of panels. The panel, I'm still waiting. So already my friend Dina has spoken to you concerning the challenges in Africa. I'm going to underscore some of those, but also look at this from a different perspective. I want to say that already there has been proof of concept in Africa in some of the countries which Dina mentioned, Egypt, Kenya, and Uganda, that guidelines do work in promoting justification. And now I want to see how can we move from that proof of concept to real practice in the real world. And we are going to look at challenges which may make it a little difficult for us to move from proof of concept to the real world, and also shall look at solutions. So this is an outline of some of these challenges which we encounter as we move from proof of concept to the real world. There's lack of policy and regulation. And I think that's really key in moving from concept to the real world, as we shall see. And then insufficient awareness in most of the stakeholders. There's a low perception of risk from radiation. We shall see that the perception of risk is really low to cause people to move. And then there's low prioritization for CIGs, for clinical imaging guidelines, and the competent authorities or the health authorities and national professional societies are not adequately involved. They are still aloof from where we want to be. There is insufficient resource that has been underscored, insufficient IT in most countries, most facilities, no computerized decision support tools, then absent or slow internet, self-referral, self-presentation, and then lack of champions. In many countries, there are no people to champion this process. The three levels of justification have already been outlined by my friend Boris. I don't need to go through them, but important for us to note that level two requires the health authorities and the professional societies to be active. And unless these are active, we shall not move from concept to real practice, to routine practice. And I think, to me, that's where the greatest bottleneck is. Of course, there's also bottleneck at level 3, where there is the individual justification, but that's, I think, is a little easier because we are dealing with colleagues. But if you're dealing with health authorities, it's another world altogether. And I think a lot of discussion has got to take place between us and the health authorities and the regulators to make them move in our direction. So proof of concept exists. We have carried out those 2 papers in our country and in other countries, and it shows that really application of guidelines definitely reduces inappropriateness. There we can see that it reduced inappropriateness greatly in our group of patients. So how can we move from proof of concept to the real world? What are the challenges there? policy and regulation. No country has a policy on justification of radiological procedures, at least to the best of my knowledge. And since no policy, there's no regulation to monitor and enforce use of guidelines. So even though they have been proved to work, we lack that. And solution is greater awareness, especially among the policymakers, and continue lobbying with these policymakers, and also have justification as a regulatory requirement, such that if a regulator visits your facility, they should ask for evidence that you're actually using guidelines. Insufficient awareness, unless awareness is created right through from health professionals to the public, to the health authorities, they will not find it logical. It's the awareness, especially about the risks of radiation, which will make them reason out that this is something necessary. So we need to sensitize them in different ways. And in the studies we've done, that we found that there's a low level of knowledge, a low level of knowledge concerning radiation and the harms of radiation, and also the use of guidelines. This is a study we published some time back, and there was a level of 73% pre-intervention and 93% when we did continuous medical education and educated the referrers. In other words, their knowledge level, their awareness rose just through CMEs, and also in a more recent study, pre-intervention knowledge of 47% and post-intervention of 59 among 120 referrers. So we see that the more you talk to these people, the more you make them aware about risks of radiation and about the value of justification, their knowledge increases. And because of a low level of knowledge, there's a low perception of risk. This study done some time back, and the question was, is the radiation risk in children higher than in adults? And you can see that still these are patients. Some patients thought that it is it's not higher. They thought it's higher in adults, but even some clinicians still thought that the radiation risk in children is not higher than in adults. And even some radiologists and radiographers still thought a little percentage though. So there are still people who are unaware that even radiation risk is higher in children than in adults. In other words, there's a lot which has to be done in creating awareness, and also in making people aware of the radiation risk. And in another study where we asked which of these has more risk from radiation, and you could see that quite a number of patients, that is the public, the referrers, and even some radiologists thought that plain X-rays carried more risks than CT scans. So we need to change this thinking. If we don't, then people are not going to use guidelines. And so education is important, and dialogue. Now the health authorities and national professional societies in Africa are not adequately, they're not yet in tune with what we want to do. And yet they are so critical for level 2 justification. And up north, authorities and national professional societies have not adequately played there. So solutions, more awareness, more lobbying to ensure that they are on board, and that justification is also regulated. And because the health authorities are not yet on board, there are insufficient resource allocation. You need resources to undertake justification, and so you find that the clinicians don't allocate the right time to ensure that they write a justified requisition. And part of this is also, of course, work overload. We've discovered in some studies we've done that definitely there's work overload. Dina talked about it. And so the solution here is to, we do think that to overcome that aspect of work overload, time, the clinicians may not have that time, and we don't have decision support tools. That vetting of requisitions at the point of care in the radiology department, which is done either by the radiologist or the radiographer, is the way to go for most parts of Africa. Of course, Boris discussed this, the pros and cons of vetting, but in our situation, we think that vetting of requisitions is one way to go. And the one who is vetting must be using the guidelines, which are evidence-based, either like the SCR or the iGuide, and use these evidence-based to vet some of those requisitions. But of course, there are examinations which from generic level are justified, like trauma, head trauma, CT. That's obviously justified. But there are things which are not justified. For instance, are you going to do a CT scan in somebody who has epilepsy? Chances are that you may not see much, or who has a very severe headache. The CT scan may help. But if it's a prolonged headache, MRI may be better. So there are some cases where level 2 justification, generic justification is obvious, but in many cases, the vetting of requisition forms, I think, is the way to go for many departments in Africa. In effect, ICT infrastructure, of course, this makes it impossible to do decision support, computerized decision support in many centers in Africa, but we see that ICT is building up, and with this we shall be able to do computerized decision support. So we'll look for more funding, train engineers to maintain systems, use alternative manuals, and where you cannot have ICT, of course, you can use analog systems. Self-referral is a big problem in Africa, and here we have to use awareness, especially not only self-referral but also self-presentation. Many times patients themselves ask for the examinations, and when a patient asks, then you have to go into explaining to the patient whether that is justified or not. So we need to create this awareness among patients, among referrers for that matter. Need for champions. We need champions in Africa. In every country, unless there's a champion in that country, justification is not going to happen. So even as I close, there's a proof of concept, numerous challenges, but awareness and also involvement of national authorities, professional societies, mentoring, and also using champions in these countries is going to be the way ahead to move from concept to real practice of guidelines of justification. Thank you.